Well, welcome everybody. Our talk tonight is on caring about pain in the person's opioid use disorder. And our speaker is Peggy Compton. This webinar has been approved for 1 nursing CE through the California Board of Nursing. At the end, if you will complete the survey, which is sent by email, and fill it out, you'll then get a pop-up that's a certificate of completion with the CE that you can download and keep. If you've missed a session, all the sessions are recorded and archived on the website, and a CE is available to you for viewing the recorded sessions. And the same process, once you answer the survey, you'll get the certificate popping up. All webinars are free to ASAN members going back, all the way from our inception and going forward. Okay. Keep your cameras on. Please mute your microphone. Post your questions in the chat box and they will be answered at the end by Dr. Compton. Peggy Compton is a professor and Van Emergen Endowed Chair at the Department of Family and Community Health at the University of Pennsylvania School of Nursing. The objectives of her talk describe the overlap between pain and addiction systems, summarize what is known about the pain responses of persons with opioid use disorder, and explain how pain sensitivity may predict risk for opioid use disorder.
Thank you, Dr. Blecker, and thank you so much for inviting me to come speak with you all. I really appreciate the opportunity to share with you some of the work that we're doing and the work that I've done over the course of my now 30 years in addictions nursing with respect to thinking about their pain and pain management needs. So let me share my screen. Yeah, so again, thank you for inviting me to come present. And yeah, I'll be talking about how we caring about pain in persons with opioid use disorder. And I guess I'll just start by saying that unfortunately, too often, clinicians who are not well versed or educated in working with patients with substance use disorders, especially opioid use disorder, don't necessarily care about the pain that they may be suffering. And I'm going to talk a little bit about some of the implications for that as I get further through the talk. So again, these are the objectives. Dr. Blecker just went through those with you, so I won't say them again. I do want to let you know that I have no conflicts of interest to disclose, and there's no sponsorship or commercial support provided to me for the development of this presentation. I do have a grant from the NINR at the NIH, and it's a grant that we're looking at ways to basically to reduce opioid use prior to surgery, with the expectation that that may improve their pain responses post-operatively. And again, I'll be talking a little bit about that body of work as well. So I just always like to begin my conversations around these topics, kind of letting you know where I come from. When I was in graduate school, I was kind of piecing together part-time work, and any of you in graduate school may know that feeling. But I was working part-time in a methadone clinic, addiction wasn't really an area that I had focused on a lot, but it was a job that, really worked well with my school schedule and really opened me up to this whole field. But then some weekends I would also float in the local acute care hospital, and it was not uncommon that I would see one of the patients from the methadone clinic who I had been working with, and I knew their struggles, I knew their families, I was very invested in their recovery. But they would come into the hospital with a painful condition, and I would see their pain being totally mismanaged or undermanaged, kind of with this assumption that if somebody's on 70 milligrams of methadone, they couldn't possibly be feeling any pain. And if they were complaining of pain, that simply meant they were drug seeking or clock watching. And so there was a lot of negative sort of attributions to their complaints of pain. And so, I kind of wondered about this. What do we know about the pain responses of people who are on large doses of opioids? And I found that there really was very little literature to guide my practice. There was a whole literature about opioids and pain and how opioids can manage pain and work as analgesics. There was a whole literature about opioids and addiction and opioid use disorder. And so there was that literature, but this was back in the early 1990s. And those two literatures were not speaking to one another. I could find very few sorts of resources to help me understand how a patient on methadone might be experiencing pain. And so that really drove my program of research. My doctoral dissertation ended up being looking at this topic, and I've continued to do this work over the course of my career. But I really feel like if I wasn't a nurse, I might never got here. I think it takes a nursing perspective to say, well, this patient isn't just in pain, and it isn't just with an opioid use disorder. This patient is suffering both. And how do they interact? And how does that then be responsible for their responses? Because this patient is suffering from both issues at the same time. And I really think it takes a nursing perspective, that kind of more holistic perspective, to think about the patients more broadly. So that's where my program of research in pain and addiction really began, was thinking about the patient and trying to understand how it could better meet their pain management needs. And you'll see that throughout this presentation, I kind of view pain and pleasure, or the euphoria that you might get from an opioid, to exist on a continuum, that there's a continuum that exists in the brain, in the nervous system, that basically one end of it would be pain or discomfort, and the other end of it would be pleasure or euphoria. And so these two feeling states are unified by existing on the same continuum. And I just pulled some pieces from literature to kind of talk about this, to kind of reflect on this continuum. Honoré de Balzac said, "For pain is perhaps a violent pleasure. Who could determine the point where pleasure becomes pain, or where pain is still a pleasure?" Sharon wrote, "Pleasure and pain, though directly opposite, are yet so contrived by nature as to be constant companions, and it is a fact that the same motion and muscles of the face are employed with both laughing and crying." So again, kind of this conceptual approach that considers that these are not unlinked human feelings or human responses. And that is proven out by our increasing understanding of neurobiology. I'm certainly not going to go through this slide entirely, but this is a slide that's basically just showing you the profound amount of overlap in brain regions that underlie pleasure or reward and pain. So we can see even at the level of the neural substrate, there's a lot of overlap between these two feeling states, which again gets at that idea that they're kind of ends of the same continuum. We see the same neural substrate involved in the experience of both. And we also know that well because opioids both provide analgesia and reward, and that both of those effects can be blocked by naloxone. So if you give a patient naloxone and then give them morphine for their pain, they're not going to feel anything. And we know from our addiction practices that naloxone is a way to reverse an opioid overdose. So this, again, this kind of combined substrate under both pleasure and pain can be demonstrated to be opioid in nature, because both of those can be blocked with naloxone. Now, my program of research has really focused in two broad areas. The first is looking at the pain responses of patients with opioid use disorder. And the second was I got pulled, because I had expertise in this area, I got pulled into the chronic pain literature, or the chronic pain practices, where clinicians were trying to determine whether or not a patient with chronic pain who was taking opioids was actually addicted, quote unquote, to their medications. And so I've done a fair amount of work looking at pain responses in patients with an opioid use disorder, and then also a fair amount of work developing tools or surveys or assessment approaches to looking at patients who are taking opioids for a pain condition, and whether or not they might need to meet the criteria for a substance use disorder or an opioid use disorder. But today I'm going to focus on the first bucket, which is really just looking at pain responses of opioid dependent or opioid addicted patients. And I'll start by just showing you a picture of the cold pressor test. This is what is a pain assay that I use in my research to determine what somebody's pain tolerance is like. Any of you who've had to go to the bottom of a cooler full of ice to pull a can of Pepsi out, you know that can become painful relatively quickly. And so the cold pressor test is actually a pain assay that's used in experimental models across research. It's a very reliable and valid way to get a sense of how sensitive someone is to pain. And when we're doing the cold pressor test, we basically look at two things. The first being pain sensitivity, which is when the cold first turns to pain. That's kind of pain threshold, when the cold turns to pain. And then pain tolerance, which is the point at which the patient says, I can't take this anymore, and they pull their hand out. So we get some nice measures of both pain threshold and pain tolerance in using the cold pressor test. One of the other reasons I like the cold pressor test, well, a couple of reasons. One is that it's relatively inexpensive, and I can carry it from clinic to clinic if I need to be measuring people's pain responses. But also, it's not a scary kind of pain assay. I mean, if you go to the dental school, they do dental pulse stimulation to see what your pain sensitivity is like. And so people, I think, won't sign up for those kinds of studies, where they may be more willing to sign up for a study where it's something like an ice bath. So anyway, most of the data I'm going to be presenting in these next few slides are looking at the pain tolerance of patients based on their response to the cold pressor test. And so this was one of my early studies, just trying to figure out what the pain responses were like in people who were either currently using opioids or cocaine, and people who were in recovery, who were no longer using opioids or cocaine. So I was kind of hypothesizing that something about, being active in your drug use may make you less tolerant to pain. And as you can see from this table, or this figure, the people who were able to keep their hand in the water the longest, up to 120 to 160 seconds, those were the X users. So whether you're an ex-opioid user or an ex-cocaine user, they were able to keep their hand in the water for a longer period of time than the current cocaine abusers and the current opioid abusers. And most of those opioid abusers were actually on methadone. They may have been using some other opioids from the street as well, but these were patients who were their primary substance of abuse was opioids. So the people who were currently using both cocaine and opioids were much less able to keep their hand in the water as long as those who weren't. And some of the explanations that we saw around this may be that people who are currently active in their disease, it results in what's called a syndrome of pain facilitation. So their discomfort is augmented by subtle withdrawal. If they're using stimulants, the intoxication or withdrawal-related sympathetic arousal or muscle tension. Concomitant health problems, if they have other health issues going on, that can make the pain feel worse. And we know for the patients with chronic pain who are not opioid abusers, but just people with chronic pain, they have sleep disturbances, they have mood changes and affective changes, they have functional changes, which all can make their pain feel worse. And we know that those same sorts of changes occur in people who are active in their disease. So that there are certain things about being currently using that could make the pain feel worse, this so-called syndrome of pain facilitation. But I think what surprised me the most was that the people who were on opioids, and these were people on, sometimes 120 milligrams of methadone a day, they were least likely to be able to keep their hand in the water. They kept their hand in the water for the shortest amount of time, telling us that they were the most pain sensitive. And again, that's kind of counterintuitive. You'd think if you were taking 100 milligrams of methadone that you wouldn't be feeling much pain at all, when in fact, these were the patients that were having the most severe pain. They were most sensitive to this cold pressor pain. And the pain tolerance was not related to the dose or the time or how long they'd been on methadone. So it didn't matter if you were on 70 methadone or 120, we still saw the same pattern occurring. So this led me to the literature to try and figure out what was going on. And I came across in the animal data this phenomenon known as opioid-induced hyperalgesia, which simply means that people taking opioids are more sensitive to pain, hyperalgesia, that they're more sensitive to pain. And in the animal models, there was a fair amount of research done on that. They demonstrated that these animals had increased sensitivity to pain resulting from them being administered opioids. They demonstrated that pain-free animal models have significantly decreased pain thresholds, nociceptive thresholds, following single or repeated administration of opioids. So something about getting opioids actually made them more sensitive to pain. And that kind of, a corollary of that is that opioids, in addition to providing analgesia, also set into motion certain anti-analgesic or hyperalgesic processes. They're more sensitive to pain over time. And so when patients are going through opiate withdrawal, and we know that hyperalgesia occurs frequently with people going through opiate withdrawal, they've got muscle aches, everything kind of hurts. That could be an unmasking of their underlying opioid-induced hyperalgesic state, that once you put them into withdrawal, that hyperalgesia emerges, you can see it. And it may also play a role in opioid tolerance. such that patients who who have pain and we're giving them opioids, and over time they need more medication to manage their pain. We call that tolerance, but it could be actually that over time they're becoming more hyperalgesic and therefore they need more opioids. So could this hyperalgesia also be a component underlying analgesic tolerance that we see when we're practicing clinically with patients with pain? Based also on the animal data, it was clear that there was genetic differences between different animal strains in terms of their propensity to develop hyperalgesia. So you can see that this strain of I think these are rats, not mice. I always mix the two up, but the LP strain there in the middle, very unlikely to develop hyperalgesia, while the first strain, AKRs, they were readily developed hyperalgesia. So this tendency to develop opioid-induced hyperalgesia varied by animal strain, which tells us there's a genetic component to it. So it could be that we all differ a little bit in our propensity to develop opioid-induced hyperalgesia. It may not happen in all of us. It may not happen in everybody to the same degree. There appear to be some genetic risk factors or genetic profiles that put you at higher risk for developing this. And I'll talk more about that later. This is just kind of a figure to kind of give a pictorial representation of opioid-induced hyperalgesia. So if we start at my left side of the screen here, you can see that you've got a pain tolerance, and that's just kind of your pain tolerance. You administer opioid, and your pain tolerance increases. That's known as opioid-induced analgesia. Also, in some approaches, they'll also call it desensitization. You're less sensitive to pain. But you can see that over time that the opioid-induced analgesia falls off, and the opponent process coming in is opioid-induced hyperalgesia. So opioid-induced hyperalgesia has been conceptualized as an opponent process, that over time, you've got opponent processes that are then driving the analgesia down and actually increasing hyperalgesia, or so-called sensitization. And it's thought that this is a functional change, such that even if you're on high doses of opioids, it's still important that you can perceive pain. It's still, if you stub your toe or break your leg, you still need, to be able to feel that pain so that you'll do something about it. So it's believed that this opponent process is a functional process. It's a good thing our nervous system does, but still that means that over time we are more sensitive to pain, and that's kind of an allostatic change, that your actual level of pain tolerance, you can see over time, becomes lower than what it was to begin with. And that gets back to that statement I made just a few minutes ago, that therefore in clinical practice, when you're working with patients who have been taking opioids, they may need more opioids over time because we think they're tolerant, or could it be they need more opioids over time because they're now hyperalgesic? So if you look at these different curves here, the A curve is normal. You've got a normal pain response. We give you opioids. You get more of an analgesic response from the medications. B is opioid-induced hyperalgesia. You can see, I'm not sure if my arrow works here, but you can see at the bottom that this area I've circled in red, they're starting out with a lower pain tolerance to begin with, and therefore will need more opioid to get an analgesic effect. Whereas C, which is what we believe tolerance to be, they're starting out at the same pain sensitivity level. They just need more opioids because they're tolerant. But you can see how in clinical practice, is it hyperalgesia? Is that why they need more opioids? Is it tolerance? Is that why they need more opioids? Very difficult to tease out because at the clinical level, they look the same. So I'm just moving on to some additional work we did following the study I presented to you a minute ago. And again, here we're still using the cold pressor test. This first box is showing comparing patients on methadone maintenance to matched normal controls. So these were healthy controls who were matched on gender, ethnicity, and age. And you can see the same sort of pattern, that patients on methadone were much less able to keep their hand in the water as long as matched normal controls. And the second figure here is we were comparing patients on methadone compared to patients on buprenorphine, which is a partial opiate agonist, to again, matched normal controls. And again, you can see that whether they're on methadone or buprenorphine, even though one's a full agonist and one's a partial agonist, we still see this same pattern, that patients on opioids were less able to tolerate the pain. And these are just some additional studies we did looking at it. This first box up here on the top is just comparing looking at cold pressor pain tolerance in patients on methadone as compared to healthy controls, but we looked at it peak and trough methadone levels, and it didn't matter if it was peak or trough methadone level, they still had the same pattern of response. And then the bottom one down here, we took patients at baseline who were on heroin before they came into treatment, and we compared those patients' pain responses or the cold pressure pain tolerance at baseline where they were still using heroin, and that's the yellow line and the blue purpley line. And we also did some control subjects at that time. And again, you can see that same pattern at baseline, that patients who were healthy controls were able to keep their hand in the water much longer than people who were using heroin. And then we followed those heroin users over time. Again, whether they were on bup or methadone, we looked at them at 4 to 8 weeks out and then 12 to 18 weeks out. And you can see that even though they moved from heroin to a treatment opioid, we still saw that same level of pain tolerance. It didn't really matter if they were on heroin, bup, or methadone. They still were less tolerant of pain than on this cold pressor test than were the normal controls. And what I found interesting as I was trying to understand this phenomenon a little bit better was that it had been talked about in earlier medical literature, and I think just kind of forgotten about. Clifford Albert Rope in 1870. Now, at such times, I have certainly felt it a great responsibility to say that pain, which I know is an evil, is less injurious than morphia, which was the term for morphine addiction back then, which may be an evil. Here, experience is needed. Does morphia tend to encourage the very pain it pretends to relieve? Charles Carter wrote back in 1908, speaking of the morphine addict, he is also affected by a hypersensitiveness to pain or a morbid intolerance of any kind of distress. He suffers. His suffering is actually great. To his astigmatic inner eye, it seems even greater than it is. So during a period of time when we were seeing a fair amount of opioid use in our society, there were clinicians who were starting to recognize this idea that they actually may be contributing to the pain that patients were feeling as opposed to simply relieving it. And we've continued this work looking at people who are using opioids prior to surgery. This study, study is not looking at people with opioid use disorder. This is just looking at people who had chronic pain and were taking opioids prior to surgery, prior to going into surgery. And it demonstrated that people who had been using opioids on a regular basis for 4 to 8 weeks prior to going in for surgery, they had more severe postoperative pain. So could this be another example of hyperalgesia? They had more acute postoperative pain severity, both at rest or while walking. They used more opioids postoperatively to manage their pain. They had a longer hospitalization, and they also had a slower rate of postoperative pain resolution. So again, kind of an indication that maybe by using opioids, even if you're not using them for a substance use disorder, but just simply using them to treat pain, you may be approaching your surgical procedure with some hyperalgesia, which then again becomes evident as we try to manage your postoperative pain. And for that reason, there are some publications out there now talking about maybe it's a good idea to try and wean these patients preoperatively to have a better postoperative outcome. Now, these again are not patients with an opioid use disorder. Those are difficult, that we can have a whole nother webinar about weaning those patients up from opioids, but these were just chronic pain patients. But so there's some moves in the literature to say if a patient's on opioids preoperatively for their pain, they may do better postoperatively if we taper them down a bit. And this is just another study kind of demonstrating the same thing. Although this study did some preoperative pain testing to look for hyperalgesia. They actually did quantitative sensory testing, which is not the cold pressor. It's another common pain assay that I've used in some of my work as well. But you can see if you look at this table at the top that they found that the patient's ability to tolerate hot pain was significantly lower in patients who were taking opioids prior to surgery. So there was evidence of hyperalgesia preoperatively. And then if you look at this bottom chart, you can see that the patients who were using opioids preoperatively also had more morphine consumption postoperatively. They were feeling more pain, so they used more morphine. So again, this idea that opioid exposure results in hyperalgesia, which can then be manifest in postoperative pain responses. And this is a similar study that we did. We were looking at patients. These were patients with opioid use disorder. So we were comparing postoperative pain responses in patients who were on opiate agonist therapy or this group, they were all on buprenorphine. So we were comparing patients who were either on a stable dose of agonist therapy for 3 months or patients that had no exposure, and they were all coming in to get some teeth pulled. We worked with the dental school on this, so that they were coming in to have some dental surgery. And all of them had a fairly significant amount of trauma associated with the surgery. The dental surgeons have this trauma rating scale, and based on how many teeth they're removing, they categorize how much trauma they're having. So these patients had on average three teeth removed at the same time, which gave them a trauma score between 5 or 10. So it was a pretty traumatic experience. This dental clinic did not prescribe opioids post-op for pain. They prescribed NSAIDs. So all the patients were prescribed NSAIDs post-operatively for their pain, but of course the patients who were on buprenorphine would also be continuing to take their buprenorphine. And what we did in this study was we compared their preoperative hyperalgesia, looking at the cold pressor test, and then we looked to see how severe their pain was post-operatively in the 3 days following their surgery, with the use of a pain diary where they kept track of their pain ratings as well as medications that they used. And what you can see in this first table or first figure here is that preoperatively, patients who were on opioids had increased cold pressor pain severity as well as heat pain. So we looked at the QST, we looked at quantitative sensory testing in this population. So we did both cold pressor and heat pain. And you can see that with both of those pain assays, the patients who were taking opioids for the management of their opioid use disorder had more severe pain ratings. They rated their pain as more severe. And then these two figures to the right are looking at their pain, how their pain was post-operatively. And again, you can see that the patients who were taking opioids, their pain severity was worse, especially up to about 54 hours following surgery, significantly so at 6 hours. And they also took more doses of the NSAIDs that they were prescribed. So again, kind of this idea that we're seeing patients who are taking opioids for the treatment of their addiction being more sensitive to pain preoperatively, and also needing more pain, having more severe pain postoperatively, as well as needing more pain medication to treat their pain. So the same pattern that we saw previously. Another kind of pain that we're getting increasingly interested in with respect to opioid use is something that's called chronic post-surgical pain. And this is a relatively new diagnostic category. This is something that you probably didn't learn about in nursing school unless you're much younger than me. But there is evidence that population-based studies find that up to 18% of patients who had surgery in the past 3 years reported continued pain in that area where the surgery was. So in other words, these chronic post-surgical pain is believed to be a phenomenon where their acute post-operative pain never fully resolves and turns into a chronic pain. And it happens in up to 18 to 20% of surgeries. And it varies by the type of surgery. I haven't included that data here, but it's kind of an interesting phenomenon that we're understanding more about. It recently became an ICD-11 diagnosis, and these are the diagnostic criteria for chronic post-surgical pain. It's pain that develops or increases in intensity after a surgical procedure. It persists beyond the healing process greater than 3 months, which is what we usually call chronic pain. It's localized to the surgical field or innervation territory of the nerves located in the surgical field. Other causes of pain or pre-existing pain are excluded from this diagnosis. And it appears to be a neuropathic type of pain because it's due to the nerve damage that was sustained during the surgery, but it should be classified as chronic post-surgical pain as opposed to neuropathic pain. So anyway, this is a lengthy introduction for you to chronic post-surgical pain. But what's interesting about this type of pain is that it appears that people who are using opioids prior to surgery, whether they're taking them to manage their pain or whether they're taking them because they have an opioid use disorder, chronic opioid use is a risk factor for the development of chronic post-surgical pain. So I mentioned at the very beginning, at the outset of my disclosures, that we're currently doing a study looking at hoping that by helping patients wean opioids prior to surgery, they'll be less likely to develop this chronic post-surgical pain. And that's actually the work that we're doing right now, is to see how the amount of opioids people are taking prior to surgery, how that predicts their post-operative pain course, but also does that predict their propensity to develop chronic post-surgical pain. So kind of an interesting new type of pain that we're interested in trying to prevent. And it turns out that opioids may be one of the risk factors for that type of pain developing. And this is just another study looking at a similar sort of thing. This is looking at the predicted probability of people continuing to use opioids at 6 months after surgery based on their daily opioid dose prior to surgery. And so you can see that patients who were not using very high doses of opioids prior to surgery were much less likely to still be using opioids 6 months after the surgery. And this is specifically in hip and knee arthroplasty population. Okay, so I'm now going to switch gears from talking about how opioids may predispose patients to being more sensitive to pain to talk a little bit about how undermanaged pain in people with opioid use disorder can result in poor outcomes, not just on pain domains, but in other domains as well. This is a study that we recently did trying to understand the role that acute pain plays in patients with opioid use disorder signing themselves out AMA or leaving AMA, what's called self-directed discharge or patient-directed discharge. Do patients with an opioid use disorder, again, they're more sensitive to pain, and if we're not managing their pain, does that make it more likely for them to leave the hospital because they know exactly how to manage their pain if we're not doing it well, right? So this study was designed to try and understand the degree to which inadequate pain management, it's been identified as a potential motivator for self-directed discharge in this patient population. But the objective of the study was to describe the association between acute pain and self-directed discharges among persons with opioid-related conditions. And I can tell you in Philadelphia now, our beds are full of people who are have a fentanyl use disorder, and that so very, very tolerant to opioids, and so their pain can be particularly challenging to manage. So the sample that we looked at for this study, we looked at it was secondary analysis of data. So we looked at a large database of all hospitalizations at acute care hospitals during 2017 in the city of Philadelphia. And this is the name of the database. It's called the Pennsylvania Healthcare Cost Containment Council database. And we examined all adult discharges who had an ICD-10 diagnosis related to opioid use or opioid poisoning being the name for opioid overdose. And you can see that of all the patients who were all adult hospital admissions from the general acute care facilities, we had over 140,000 admissions for close to 100,000 people. We excluded those admissions that did not involve an opioid-related diagnosis, and therefore our final sample that we analyzed these data for was close to 8,000 admissions, which was accounted for about 6,000 people. Our methods for this study, we looked at the patient discharge status. It was determined by a code used to indicate that the patient disposition upon discharge is supplied by the facility, the code that they used. Those that were coded as left against medical advice or discontinued care were classified as self-directed discharges for the purposes of these analyses. And since we wanted to get a sense of what's the role of acute pain in these self-directed discharges, we, 2 PhD prepared nurses, registered nurses with extensive clinical experience in substance use and acute pain, independently coded each primary admission diagnosis as either being acutely painful or not acutely painful. So we were looking to see those patients who had an acutely painful diagnosis, did that put them at higher risk for leaving because perhaps their pain was undermanaged? Fortunately, the initial agreement between the two nurse coders was 91%, and the remaining discrepant cases were resolved upon discussion. So the results, 16% of those 8,000 admissions involving opioid-related conditions culminated in a self-directed discharge, an AMA discharge, which was more than 5 times higher than the general population. Self-directed discharge rates were positively associated with polysubstance use, nicotine dependence, depression, and homelessness. Among the 955 patients with at least one self-directed discharge, 15.4% had up to an additional 16 self-directed discharges during the 12-month period. So these are people, a lot of these people are cycling in and out. They come in, have something managed very quickly, but for one reason or another, they're leaving as well. But those that were admitted with an acutely painful diagnosis were almost twice as likely to complete an AMA discharge. So that demonstrates kind of that relationship between having really acute pain and leaving, which again may be related to their pain not being managed well. And for patients with multiple admissions, The rates of having an acutely painful diagnosis increased with each admission, coinciding with cascading pattern of worsening usually infectious morbidity over time. So that each time they came in, they had an even more severe acute pain diagnosis. So each time they came in, they were looking to be experiencing more pain. And this is just a case study of one of these patients. You can get a sense of what they're going through. This patient was a 56-year-old man who was admitted to a general acute care hospital 16 times in 2017, each time through the emergency room. All but the first discharge was self-directed, with lengths of stays for those discharges ranging from 0 to 3 days. Although he had opioid use disorder and an opioid dependence diagnosis, none of the admissions were related to overdose. All admissions were for painful infectious conditions. Specifically, he was admitted with a primary or secondary diagnosis of cellulitis in the right lower extremity 9 times, which progressed to an osteomyelitis of the right tibia by his 12th admission. Also noted were his cocaine use disorder, cannabis dependence, alcohol dependence, and nicotine dependence. On 8 of the admissions, he was noted to be homeless. This patient had Medicaid insurance coverage, and the total cost associated with his care was nearly $500,000. So we spent $500,000 on this poor patient who cycled in and out and in and out, and it had increasing morbidity over time. Each time they came back in, they were even sicker. And so to the degree that unmanaged or undermanaged pain is precipitating this leaving of the hospital and things getting worse, it really speaks to a necessity to intervene with these patients to make sure they're more comfortable and aren't leaving. So the conclusions of this study were that individuals admitted to the hospital who have an opioid-related diagnosis are more likely than those without to experience self-directed discharge. Rates of self-directed discharge likely reflect unrecognized or poorly managed pain. Notably, a significant number of these patients experience multiple and repeated self-directed discharges from acute care settings with worsening morbidity and increased cost over time. And again, these findings underscore the importance of good pain care in disrupting the process of self-directed discharge, intensifying harm, and preventable financial costs and suffering. Okay, now I'm going to switch gears again because I want to make sure that I'm able to, talk a little bit more about this opioid-induced hyperalgesia. And I'll just point out from the previous study, if these patients are coming in with an opioid use disorder, they're very sensitive to pain. Okay, so their acute pain is feeling more severe than in a patient in the bed next to them who's not taking opioids. So we really need to be very aggressive in terms of managing their pain. But I now want to flip this whole discussion of opioid-induced analgesia on its head by presenting some data that argue for perhaps a different reason that patients with opioid use disorder are so sensitive to pain. This is a study that continued to look at hyperalgesia following opioid detoxification. These were patients who were taking, I believe it's all methadone. I don't see it down here, but I believe it's all methadone because it's 2006, so it was a while ago. But you can see that the latency, which is threshold for pain, their tolerance for pain, and how intense they rated their pain didn't change from baseline. So even after they'd been without opioids for 28 days, they still didn't get much improvement in their pain responses. So simply taking the opioids away didn't make them suddenly more pain tolerant. Now, this is only looking at 30 days, but you might expect that over 30 days that we would see some improvements in their pain responses. So that leads to the question, is the hyperalgesia we see in patients on medications for opioid use disorder, MOUD, is that hyperalgesia actually opioid induced? Could it be that people who are prone to abuse opioids are hyperalgesic by nature? And this this figure here is simply showing you the normative responses of people on the cold pressor test. So you can see that about 1/3 of normal healthy controls are relatively pain intolerant. They can't keep their hand in the water for more than a minute or so. Whereas about 2/3 of the normative population can keep their hand in the ice water for up to 5 minutes. They're relatively pain tolerant. Could it be that the patients we see in our methadone and buprenorphine clinics are the pain intolerant people, that they're just pain intolerant by nature? These are some data looking at different studies that have compared patients' pain responses in people who were on opioids, people who were who had an opioid use disorder but were no longer using, and matched controls. And you can see across these different studies that the patients who were not using opioids anymore still had poorer pain tolerance than matched control healthy patients, which again speaks to this idea that maybe people who end up in our methadone clinics or our buprenorphine clinics are just really pain sensitive individuals by nature. Oops, sorry about that. And this is just animal data, going back to the animal data, but you can see that in these different strains of animals, that the bulb C and the CXBH strains of animals, they have very high pain tolerance. They get a great analgesic response if you give them an opioid, but they don't get a lot of reinforcement from opioids. They don't find them highly rewarding. Sometimes you have to hide the opioids in their food to get them to actually become opioid dependent. And they don't tend to develop opioid-induced hyperalgesia. Whereas the C57s and the CXBKs look a little bit more like the patients that we see in practice. They have poor pain tolerance to begin with. They don't get a great analgesic response when you give them opioids, but they find the opioids highly rewarding, very reinforcing. These animals will easily self-administer if they find them very rewarding. And they're also more likely to develop opioid-induced hyperalgesia. So could it be that the patients we're treating in our opioid use disorder clinics are actually more like the C57s and the CXBKs? They start out with a low pain tolerance and find opioids highly rewarding. And if you've got a low pain tolerance, that can make going through withdrawal or detox even more uncomfortable. So they have more difficulty perhaps detoxifying from their medications. And this is a small study that kind of hints at this, perhaps. I don't know if you're all familiar with the SOAP. The SOAP is a tool it's a screener and opioid assessment for patients in pain. So it's a tool that's used in chronic pain clinics to determine whether or not a patient is at risk for developing opioid use disorder. And they took patients with chronic pain, patients that were on no opioids, patients on low doses of opioids, and patients on high doses of opioids, and they gave them a painful stimuli, this punctate mechanical stimuli. It's kind of like a little needle that causes pain. And when you compare, I can't quite see it here. When you compare patients who scored high on the SOAP, meaning they're at risk for developing opioid use disorder, they're at risk for substance use disorder, you can see that regardless of whether they're on opioids or not, they rated the pain as more severe. So again, giving us this idea that perhaps patients who are more sensitive to pain are also more likely to develop an opioid use disorder. They are more likely to have the risk factors that go along with it. And this is some work we did trying to kind of discriminate between patients. These are chronic pain patients. These are not people with opioid use disorder, but patients who did or did not develop opioid use disorder when they were given opioids for the treatment of their pain. And we based these data on 12-month chart review as well as clinician interviews. We compared 20 patients who did develop opioid use disorder. And these were the inclusion criteria: that they weren't previously had a substance use disorder, that they developed the opioid use disorder over time, and they were actually receiving treatment for an opioid use disorder, compared to patients who had chronic pain, were given opioids, and never developed an opioid use disorder. They had no current or past history of substance abuse, no evidence of aberrant drug-related behaviors, meaning they were calling in for early refills or losing their scripts. All their drug urine screens were clean, and they did not endorse the DSM-4 criteria for opioid use disorder. And so we found that when we looked at the pain responses of those patients, the ones who did develop an opioid use disorder and the ones that did not, those with the opioid use disorder rated the pain, whether it was cold pressor or heat pain, they rated it as more severe. And we actually saw more what's called central sensitization in the people who developed opioid use disorder, that they were more likely to have an increase in the pain transmission over time in the spinal cord. So there were differences between the two groups, the ones that did develop opioid use disorder and the ones that didn't, and these differences were evident on their pain responses. So I've thrown a lot at you, but in summary, I would say that the key takeaways from this presentation are that pain and opioid use disorder are interrelated phenomena. The patients on opiate agonist therapy, like buprenorphine and methadone, have an increased sensitivity to pain. It looks like opioid-induced hyperalgesia, but whether that heightened pain sensitivity is totally due to the opioids or is it a trait that they come to opioids with is not clear. But overall, complaints of pain from patients with OUD should be taken seriously and managed aggressively. They likely are feeling more pain than the patient who's not using opioids. And as you saw from the one study we presented, if you don't manage their pain, they may leave treatment and ultimately develop more severe disease or symptoms. So I've listed some references in case you want to look a little bit more into this literature. And I thank you for your attention. And if you've got any questions, I'd be happy to take those in the few minutes we've got left here. We've got about 10 minutes left. I can stop sharing.
You can either unmute and ask a question, or you can put it in the chat if you have a question.
I'm seeing a couple of them here. Were you able to flesh out the ages of patients and find out if age was a factor? Is there any difference in the in younger patients versus older patients? Not with respect to opioid-induced hyperalgesia. We do know in general, over time as we age, people become somewhat less sensitive to pain. And that's believed to be due to neuropathies that may be developing. But with respect to opioid-induced hyperalgesia, we haven't seen a difference in the age of the patient as to whether or not that predicts their propensity to develop opioid-induced hyperalgesia. Although I can't say that good studies have been done to really tease that out. And then another comment, it sounds like there's a lot of stigma related to the undermanaged or poorly managed pain management. Agreed. I mean, I think that's really, one of my soapboxes that I'm on all the time is that the stigma that goes along with being having a use disorder and this kind of assumption that people who have an opioid use disorder, they don't really have pain. They're just, they're just drug seeking as opposed to really having pain. And one thing I hope that you take out of this presentation is they may actually be having more pain because they've been using opioids or because they have an opioid use disorder. How do you treat the pain for someone on Suboxone or methadone? It's a great question. One thing, if they're coming into the acute care setting, one thing that should not be done is playing with their methadone or buprenorphine dose. If they're on a stable dose and they've been doing well on that dose, this is not the time to kind of decide to manipulate the dose. And so basically treating their pain is the same as treating anybody else's pain. You look at their pain severity score and you provide opioids to manage that pain. And whether it's due to tolerance or hyperalgesia, they're likely going to need more opioids than the average patient undergoing that same procedure. But we just want to keep them comfortable. There was some concern years ago that Suboxone, being a partial agonist, might prevent the patient from receiving a full agonist effect from opioids that we give to manage their pain. But subsequently, that's been demonstrated not to be true, that even if they're just on the partial agonist, we don't have to flip them over to methadone. We don't have to decrease their buprenorphine dose. They can still perceive opioid analgesia. But one thing I would talk about with respect to these patients, if there's a concern, we have a concern perhaps that their methadone or buprenorphine may be making their pain worse, that we should often consider opioid sparing ways to manage their pain. There are good non-steroidals out there that can be given. People are using ketamine as an alternate way to manage their pain. Tylenol is a good drug in terms of managing pain. So to the degree that we can, let's not give them more opioids, which may only contribute to their hyperalgesia more. Let's also think about other types of pain medications that we could use to manage their pain, that to the degree that we can. I'm not saying opioids shouldn't be used with those patients, but maybe we won't have to use quite as much opioid if we're also combining it with a non-steroidal or another gabapentin or another type of agent. Is this phenomenon with pain challenges also shown with other addictions such as alcohol use disorder? It's a great question. It is not, this idea of opioid-induced hyperalgesia, it definitely has not been demonstrated in other addictions. One thing though we are seeing is that patients who are alcohol users and nicotine users, when they're going through withdrawal, their pain feels worse. So if they're coming into the hospital and they're suddenly not getting their nicotine and they're not getting their alcohol, they are going to have some hyperalgesia associated with that. So it appears that anytime a patient is in withdrawal from any of these substances, whether it's a stimulant or nicotine or alcohol, if they're in withdrawal, their pain does feel worse. But I haven't seen any literature to show that alcohol dependence by itself contributes to hyperalgesia. We do see it appearing, though, when people are withdrawing. Great question. So the Suboxone won't block the Percocet in the urgent care setting. The data says no. They may need more Percocet than the person who's not on buprenorphine, but there's been more kind of adverse events for when we try to take somebody who's stable on their buprenorphine and switch them over to an agonist or stop the buprenorphine, that patients tend to do worse with that. So just to keep their buprenorphine stable and provide the Percocet on top of that, they may need more Percocet than the average patient would, but there's no, the data at this point are saying, no, don't fiddle with the buprenorphine dose, just provide them the opioids. These are great questions.
Do you find it difficult to convince a patient to keep their dose or to come off their dose? Is that hard? Is that a big fear?
With respect to coming for a surgical procedure, or?
Well, if they're experiencing hyperalgesia and you want to lower their dose.
Yes. Yes, but I always remind the patient, just like we saw with those mouse strains, that there's a genetic component to it, and not everybody is suffering from hyperalgesia. Not every single person that we've got on opioid therapy is necessarily suffering from opioid hyperalgesia. But if I'm working with a patient with chronic pain and we're having difficulty getting their pain managed, we will talk about the fact that the opioids may be contributing to the pain feeling worse. And so we could try a trial of detoxifying, not detoxifying, but bringing the dose down a little bit and seeing if that helps. But certainly, especially patients with opioid use disorder, there's going to be a lot of pushback in terms of decreasing their dose. And so I would not want to think about decreasing their dose in a surgical setting, in an acute care setting. If they've been coming to the clinic for, 6 years and they have chronic pain but they're very stable in their recovery and stable on their medication, that may be a situation where we could talk about the fact that their buprenorphine may be contributing to their pain. And let's see what happens if we bring you down a little bit. But I always keep in mind that kind of individualness of it. Those animal data show us that not all animals will develop opioid-induced hyperalgesia. So I'm not convinced that every single patient taking opioids will develop it. There's a trend in that direction, but.
What about use of marijuana? I've had 3 elderly people who use medical marijuana and have cut their opiate use more than half.
The data are just emerging on that, but we're hearing a lot of stories about that. In the acute care setting, it's not something that will be at this point prescribed. But for patients with chronic pain and who are taking opioids, we're hearing a lot of reports of that. We just need more research on it. For so long, marijuana was a class 1 narcotic and nobody was really looking at it. We're starting to see some research emerge, but I'm like you, hearing a lot of reports from patients that the marijuana really cuts their opioid need.
I've had two elderly women. One was prescribed an opiate 3 times a day, and she got totally off the opiates using medical marijuana. The other one was prescribed up to 4 times a day, and she said she used an opiate maybe once or twice a week.
Yeah, I think there's a real role for it. We just don't, the data is starting to accumulate. I'm working with a graduate student right now who's looking at, those of you who work in methadone clinics, you probably know there's a high percentage of patients on methadone who also have chronic pain. So you're dealing with both those things. And so he's looking at the use of marijuana in addition to their methadone to see if he can, not only perhaps affect some of the addiction kinds of outcomes that we look at, but can that help to improve their pain? Most methadone clinics don't want patients on anything other than the methadone, but if we can demonstrate efficacy, we could maybe move things in that direction a little bit more. I see we have 2 more minutes. Is there, I see one. And do you ever use an increased dose of Suboxone for pain management rather than Percocets or other analgesics? Yes, I do work with some clinicians that do that, but they have to split the dose because buprenorphine, like methadone, to cover opioid use disorder, you can give it once a day, but to cover pain, you may need to give it you may need to break the dose up and give it 2 to 3 times a day. But I have seen that done. It just means you need to change the dosing regimen. You give the same dose, but you split it. Yes, and I can certainly share my email address. I don't know if it's on the flyer, Suzanne, that was sent.
No, I don't think it is.
Okay. Well, I can, please, Dr. Blacker, feel free to send my email address to all of our attendees.
Do you want to write it in the chat?
Oh, I can do that. Yes. Thank you. Well, I see it's 8 o'clock. So again, I appreciate your attention and great questions, and I appreciate the opportunity to speak with you all.
Thank you so
Thank
much,
you.
Dr. Compton. That was a great presentation.
Thanks. Have a
Very
good night.
good.